Masterclass, and it gives me immense pleasure to welcome you all today evening for this first ever physical masterclass in the series of Reproductive Medicine Masterclasses conceived and conducted by Dr. Abha Majumdar. Today we are all here to celebrate the remarkable milestone in our quest to empower professionals and clinicians in the complex journey of infertility practice. And we are here to acknowledge this extraordinary individual who has embarked on a remarkable journey to empower students and practitioners all over the country. Dr. Abha Majumdar, a seasoned educator, has generously taken it upon herself to conduct free online masterclasses for all of us. This journey started in February 2024, and every Thursday, ma'am continued to illuminate the path for countless aspiring minds. We covered around 18 topics still present, which included infertility diagnosis, treatment, options, ART technologies, latest research, and breakthroughs in the field. Each time, a large number of participants have engaged in thought-provoking discussions, clarifying complex concepts. Dr. Abha diligently answered each and every question, and during the process, not only that, we all ended up learning new things and tweaked our practice for the benefit of patients. We extend our heartfelt gratitude to Abha ma'am for her visionary leadership, tireless efforts, and the generosity of spirit. Ma'am, your contributions will have a lasting impact in the field of assisted reproduction and beyond. Taking the program forward, I would now call upon my colleague, Dr. Bhavani, to invite the speakers.
So now we begin with the lectures. So the first lecture is on embryology for clinicians. We clinicians in IVF need to be well versed with the embryological aspect of IVF to optimize our results. And to throw more light on this, I would like to invite Dr. Gaurav Majumdar sir on stage to deliver his lecture. Sir needs no introduction. He's the chief embryologist of Center of IVF and Human Reproduction, Sagangaram Hospital. He's the backbone of our IVF center and has a major contribution in making our IVF department what it is today. I welcome you, sir.
Hello, yeah. So good evening everyone, and it's a privilege for me to be invited to be part of this popular masterclass series, and thank you to Dr. Abha to have me part of this. So this is this whole concept that we came up with about embryology for clinicians last year. So why do clinicians need to know about embryology? Are we here to teach them embryology? No. Well, there are enough CMEs which are organized by embryologists for embryologists, and each CME deals with teaching embryologists how to optimize the IVF lab, KPIs, and how to optimize different important procedures like vitrification, ICSI, how to do embryo selection. But yet, it's somewhat bizarre that we continue to witness practices which are subpar in IVF around us, like transferring large number of embryos. We continue to vitrify large number of embryos. We adopt ineffective culture strategies like freezing embryos on day 3, etc., etc. So clearly, none of these CMEs have actually helped in improving the standard of embryology practices in an IVF lab. which are actually key to improving patient care. So when I thought hard about this, it was probably because it is the clinicians who are the dominant force in IVF laboratories, and they are the ones who call the shots as far as making policies of the IVF laboratory, which concern the embryology laboratory also. So I thought that it is high time that clinicians should be made aware about the real performance of the IVF lab and other very important things. So in this lecture, we'll not be teaching anything technical, but our focus points would be to see the importance of the choice of method of fertilization, then what are the key performance indicators in the laboratory, and how it is vital for a clinician to know that the only way to make your results more consistent is by following regular reporting and data analysis. Then it's very important for a clinician to know when the laboratory is not performing and what are the questions and what are the areas they need to look at in the embryology lab. A clinician has to know this, and apparently clinicians don't have a clue when things go wrong in the laboratory. Then one thing that we realized is for clinicians, they are much at a loss in their OPDs when they're shown pictures of embryos. So they should at least have a fair idea about what embryos look good and what don't. Then again, this is a very important decision that clinicians should be helped by the embryology laboratory data about how many embryos should be transferred, how many embryos should be vitrified, when a blastocyst transfer should be performed or when not. So these are some of these were the key focus points of this entire thought process of embryology for clinicians. Well, within the scope of this lecture, I'll just touch upon few of these points. So we will be talking about key performance indicators. We'll be talking about the method of fertilization, the choice of the method of fertilization. Then we look at the number of embryos for transfer and a little about quality of embryos. So let's start with key performance indicators. We know that the major aspect to clinical embryology is a technical one. But there is also a very important cerebral aspect. And we always think that the technical skills required for performing embryology effectively are speed, a lot of accuracy, precision, and one needs a lot of attention to detail and awareness about what's happening in the laboratory at all times. But the cerebral part comes through the next step. After you finish doing your procedures comes the incredible amount of documentation, which is very, very laborious and highly painstaking, takes a lot of time, takes a lot of commitment. There are clinical parameters to be recorded, there are embryological parameters to be recorded, there are treatment follow-ups, outcomes to be recorded, and all of this is for the sake of data analysis. Because it is this data which comes out of our work is what will eventually help us in assessing the true performance of the IVF laboratory. The performance cannot be assessed through anecdotal incidences where a clinician or a embryologist may refer to a particular case and then form an impression about the overall performance of IVF lab. No. It's through detailed data analysis of all the work which is going on in the laboratory. So it is very important to know the performance of your own laboratory. And I'm going to tell now the clinicians of how to do that, or at least know how it is to be done so that they can go back to their laboratories and try to look at this. So this is done through making control charts. It's very easy, can be done through Microsoft Excel that everybody of us has access to. And I will give you a quick demonstration of how we do it for, say, one of the key performance indicators, which is fertilization rate. So that's a simple KPI. So these are patients who underwent IVF in a particular month. So we record the average fertilization rates for each patient and then take out a mean of the same for each. And we do that exercise for every month of the year. So this gives us the mean fertilization rate. And then from the mean, we can calculate the standard deviation, which then gives us the upper control limit, which is nothing but mean plus 2 standard deviations, and the lower control limit is the mean minus 2 standard deviations. And then we just put all this data on the Excel and make a line bar, right? So here, this is the mean, this purple line here. These 2 lines signify the upper limit and the lower limit. And now we can see that the fertilization rates in the month of August, they dipped below the lower control limit. So this shows that now this is something which cannot be owed to biological variation, right? Because there's a lot of biological variation. But this is probably due to something else which has gone wrong in the laboratory, which has actually brought down the performance of the laboratory, and so major troubleshooting needs to be initiated at this point. So a clinician should be aware, because without this, it is impossible for any human being to know about the performance of the laboratory. And here, this is with respect to just simply fertilization rates. You can do, and this can also help you compare, the performance of different procedures in the laboratory. For example, this gray line here is showing us the fertilization rate for ICSI, and this is the fertilization rate for IVF, and this is ICSI again. So we can plot multiple lines on the same graph to know about, to compare different outcomes. Now we can do it for clinical outcomes like ongoing pregnancy rates, for live birth rates, for frozen cycles, for fresh cycles. So this can be, these kind of charts can be made for every single performance indicator, and then you can see where you're going off limits. So clinicians need to know when they are trying to assess operator performance or embryologist performance, then which are the KPIs to look at? You need to look at 3PN, 1PN rates, ICSI lysis rates, fertilization rates, cryosurvival rates, which are directly linked to operator performance. Then how do you assess the culture system of your laboratory? When sometimes the clinicians are very wary of the fact that for some patients, they may see poor embryos or no embryos or very few blastocysts. Then rather than relying on anecdotal instances, it is important to pull up this data from their laboratories, and where they look at the blastocyst utilization rate, the day 3 top quality embryo rate, or the IVF fertilization rates. How does one assess the quality or the efficiency of the embryos which are generated in one's lab? The best marker for assessing the quality of embryos being made in a lab is the implantation rate, and to some extent the miscarriage rate also, because miscarriage rate is a far-reaching consequence again of the culture system, which is reflected by embryo quality. And finally, the overall clinical performance is visible through looking at clinical pregnancy rates, ongoing pregnancy rates, and finally live birth rate. So these are all areas, these are all parameters which should be available to the clinician, or at least the clinician should ask for this data when they need to see how their laboratories are performing. Now let's move to the next topic in the list, which is looking at the choice of method of fertilization. And we know that over the past 2 decades, we have seen an alarming trend of moving towards intracytoplasmic sperm injection, even in cases where there's no indication. Initially, ICSI was developed only for male factor infertility, but now everyone seems to think that that is the method of choice. So, why did this radical shift occur from IVF, which is actually much easier to perform, doesn't require any proficiency, doesn't require any skill. You just plonk the processed sperm with the eggs and just let nature take its own course. Well, because of the uncertainty which is associated with natural fertilization. And all of us are very desperate for a procedure which can completely eliminate any chance of total fertilization failure. Also, due to a belief that all of us hold, is that when we inject a sperm physically inside the cytoplasm of an egg, there's obviously going to be a higher likelihood of fertilization, and therefore more fertilization will bring about more embryos. Also, a very important point is justification that we did the best or more than best for our patients, probably, and also working hard, toiling in the laboratory for extra hours is perhaps considered as a sign of dedication and hard work. Well, so like I said, so this choice mainly is governed by this fear of risk of total fertilization failure or poor fertilization. One can never be sure about what's going to happen. It's every time is a roll of a dice. But I would like to analyze this choice on a more important parameter which actually escapes all of us, and that is the number of embryos that we are able to make at the end of a cycle depending on the mode of fertilization chosen. So to highlight this fact, we've recently finished doing a sibling oocyte study where half the eggs from the same patient were subjected to IVF and the other half to ICSI. And this is perhaps the best model to study the, value of performing either procedure. So what we found was astounding. The first thing, so we started off with large number of eggs, about 1100 eggs, and so in both the arms we split the eggs equally. So all the eggs were subjected to fertilization with IVF, but with ICSI, only out of about 9 eggs, only 7 got subjected to ICSI, which means all the immature eggs, they get left out of the equation. Now, what downstream effect this leads to is that the fertilization rate per egg, which is utilized, becomes much higher, statistically higher with IVF, which is 66% versus 54% for ICSI. If we look at the ICSI per M2 oocytes, then that fertilization is similar to IVF. But only owing to this poor utilization of oocytes with ICSI, the overall fertilization rate comes down. And this then further downstream leads to what you can see here. In the IVF arm, we were able to produce 291 blastocysts vis-a-vis only 202 blastocysts in the ICSI arm, right? So which is a huge, huge difference. So the mean number of blastocysts utilized was found to be statistically much higher when IVF was employed. And another important factor that we are very worried about all the time is the number of total fertilization failures. So out of these 125 IVFs which were performed, only 4 ended up with TFF, which is a percentage of 3.2, whereas there were none with ICSI. So now you have to make a choice. So it's a compromise between a likelihood of 3% of TFF versus almost 90 fewer blastocysts. And when we took out the odds ratio, we found that there was a 34% reduction in the odds of obtaining a good quality blastocyst in the ICSI arm when compared to IVF. So this is the choice you are making between a 3% chance of TFF and on the other hand having a 34% reduction in chance of making a good quality blastocyst. So keeping this in mind, in future you should make decisions. So our expectation always is that ICSI will lead to higher fertilization and more embryos per cycle with no fertilization failures. But the reality is different. Actually, we see that the fertilization rates per allocated egg are always lower in ICSI. And when the lesser number of eggs utilized, the number of embryos produced will always be lower. And the chance of TFF is actually similar in both IVF or ICSI. So we cannot eliminate that risk of TFF even with ICSI. So, but still we know that there are a lot of real life dilemmas of whether to do IVF or ICSI, especially in poor responders, then patients of advanced stage, then very importantly in patients of unexplained infertility with or without long-standing infertility and PCO. Then we've got patients with endometriosis and patients with previous failed IVF ICSI cycles. So this is just, I've just gotten a couple of tables here to illustrate few points I'm trying to make. We won't go into all the patient subcategories. Is that, for example, in poor responders, again we see that with IVF, all the eggs get utilized, all of the eggs get a chance to fertilize, whereas here only 80% of the eggs, when we choose to perform ICSI in these patients, we start out by losing out on 20% of cases, right? And this results in a higher fertilization rate, and which further downstream results in larger number of blastocysts, and which can be game-changing in these patients where already there are very few eggs, and they are relying on that one blastocyst to give you a chance at pregnancy. Also, one interesting fact that we found here was that the chance of having a fertilization failure was actually much higher in ICSI than compared to IVF, which means that when we are dealing with one egg, for example, then there's a higher chance of damaging that egg if we choose to do ICSI. And that is what is leading to such high levels of TFF in poor responders. Now, the second patient group that I wanted to talk about here was patients with unexplained infertility with PCO. Now here, again we see the same trend where performing IVF gives you the highest fertilization rate vis-a-vis ICSI, which is much lower. And then in a lot of patients we do a split insemination between IVF and ICSI, so which is intermediate between that of IVF and ICSI. Here one can see that the likelihood of having a TFF is double that of ICSI. So here there is a strong case of performing half IVF and half ICSI. So this is something which I wanted to emphasize. So in our experience, IVF works, especially for young patients with small duration of infertility, tubal factor, in patients with histories of past pregnancies, for example, if they've had miscarriages or ectopics or live births. So it's a no-brainer to do IVF in these cases. And what our data shows is that, again, IVF is more beneficial in poor responders, in patients with advanced stage, endometriosis, patients with mild teratozoospermia, and previously failed ICSI cycles. All you need is a good post-swim-up motile sperm count, and you're good to go. Only in cases of unexplained infertility should you take some precautions and perform ICSI on half the oocytes. So that was all about the mode of fertilization. Now let's skip over to the effect of number of embryos on outcomes. So this is something which is very important, where it's important to see a hardcore data for us to know what effect does increasing the number of embryos have. So here you'd like to see, so I'll quickly tell you, so this is a comparison between 1 day 3, 2 day 3, then 1 day 5, 2 day 5 embryos, 1 day 6, and 2 day 6 embryos. So you can see within day 3 embryos, transferring 2 day 3 embryos actually doubles the live birth rate from 20 to 40. So obviously it makes total sense to transfer 2 day 3 embryos and not just 1 day 3. But look at the data for day 5 blastocysts. Both the rates are equivalent, irrespective of number of embryos transferred. Similarly, for day 6 embryos, again, both rates are equivalent. There is no difference. These levels are not statistically different. What changes but is the multiple live birth rate per embryo transfer. So here, transferring 2 blastocysts leads to a 10% twinning rate, and here again there is a appreciable 15% twinning rate when 2 blastocysts are transferred. What you can also see here is that when 2 day 3 embryos are transferred, the twinning rate is very low. So actually it makes a strong case for transferring 2 day 3 embryos, because despite 2 embryos, the chances of both of them sticking are actually quite low. So take-home message here is that please don't transfer 3 or more embryos. It will lead to an incredibly huge number of multiple pregnancies. And one redeeming piece of information is that multiple pregnancy rates are still quite low when only 2 embryos are transferred. So we saw the maximum rate to be about 15%, which is quite permissible. Transferring more embryos can never compensate for poor embryo quality or a poor laboratory. And such laboratories continue to have poor pregnancy rates, but a much higher complication rate, as most of their pregnancies are achieved in multiples. Now, what is the effect of number of embryos on vitrification outcomes? Again, so the same follows, where now it's important for clinicians to know that the survival rates achievable with vitrification are more than 95%, which means that vitrifying a single embryo poses no risk of cycle cancellation. And so if you are told otherwise by your embryologist, you should check with their proficiency of vitrifying embryos. These are standard procedures which are now considered standard of care and are performed across the world with very high survival rates. So vitrify only the number of embryos you want to transfer. Don't vitrify 4 embryos together while intending to transfer only 1 or 2 embryos. This is a thought process for people who know that routinely embryos get damaged. And so they try to freeze more embryos. So if this is happening in your laboratory, you need to take notice of this and call out your embryologist on this. Then vitrification is most efficient when embryos are vitrified individually, and it is more robust at the blastocyst stage, and often vitrifying poor quality embryos will lead to poor survival rates. So if you are getting poor survival rates in your laboratory, then it means that there's something wrong with the embryo quality also. Now, a little bit about the quality of embryos. So you should be able to look at embryos and at least have a fair idea about how they look. So we know that the most important feature now, contrary to landmark evidence which was published back in 2011, 2012, is that the size of the inner cell mass. So that is what determines the robustness of implantation. So an embryo with a large inner cell mass is most desired, has the highest implantation potential. And so you can see that these are embryos with progressively decreasing sizes of inner cell mass, right? So the inner cell mass from A goes to B, and from B goes down to C, right? And with the inner cell mass becoming smaller and smaller, there is a major reduction in the implantation potential of these embryos. All three embryos look fantastic, right? With a lot of cells, and they look very beautiful. But this is what you need to see. Okay, where is the inner cell mass? Or is there any inner cell mass or not? Because that is the main determining factor. Similarly then, looking at embryos with very poor inner cell masses and poor trophectoderms. So when you see these embryos, you know, and especially when you see reports from other centers, you can have a quick idea about whether you're actually dealing with patients who had very poor embryo quality in the previous cycles. So this is just so that you get tuned to looking at embryos. Often we look at embryos in reports of other patients and we find those embryos to be appalling. But there isn't any mention of that anywhere. We confirmed this because we perform a lot of single embryo transfers, and we could see that patients with embryos with AA grade had actually the highest live birth rate and implantation potential in our IVF lab, and then this progressively decreases with decreasing embryo quality. Similarly, again for day 6 embryos, we see the same, that the live birth rate for day 6 blastocysts, it decreases with decreasing embryo quality, with the lowest pregnancy rate with AC embryos. CA embryos are actually the worst performing, lower than AC embryos. And this is what we were able to get all this data because of our practice of single embryo transfer, which did not happen overnight. We developed this over many years, starting from 2015, where only 33% of our embryo transfers were single blastocyst transfers. But then we took a conscious decision of reducing the number of embryos that we were transferring in the laboratory, and which included a lot of optimization of the laboratory. And slowly you can see year after year, in 2016, this 33% went up to 59%, then it went up to 61%, and then 70%. And finally now we are somewhere at about 80%, where 80% of our embryo transfers are single blastocyst transfers. And we are very proud of the fact that after 2017, we never transferred 3 embryos ever again. And currently, we transfer only about 10%, in 10% cases where we are transferring 2 embryos. And what it has done to our outcomes, clinical outcomes, is that progressively from 2015 onwards, our implantation rates have gone up. And our multiple pregnancy rates, which were close to 16% in 2015, have actually now gone below 5%, which is a huge achievement in terms of outcomes of IVF laboratory. So this was all I could include in this nutshell to give you some tips about these embryological parameters and information that clinicians must know in their laboratory. Thank you very much for your time.
So if there are any questions, we'll take them at the end of the second lecture. So thank you for this comprehensive lecture. I'm sure all us IVF clinicians have gathered a lot of take-home points from this lecture. So this journey of masterclasses with Abha ma'am has been truly inspiring and a learning experience for us. And adding another lecture to this series, I would now welcome ma'am. As we say that one size doesn't fit all, so similarly in IVF stimulation protocol also, one stimulation protocol cannot cater to all IVF patients. We need to individualize the stimulation protocol according to the patient characteristics. And to throw more light on this, we have the legendary, the stalwart, Dr. Abha Majumdar ma'am, Director, Center of IVF and Human Reproduction, Sir Gangaram Hospital. We welcome you.
thank you all my colleagues and Intas Pharma for making me realize my dream of teaching all, not just my students, but they are such brilliant clinicians, and all these master classes have not led to teaching them, but me learning from every master class also. And it has been a great experience, great journey. Why? Have you connected it? I'm still reeling under the effect of Gaurav's lecture because he's an embryologist. I'm speaking about him not as a person known to me, but as my embryologist, that he has made it possible for us to reach a single embryo transfer stage only by upgrading the laboratory to such standards that we clinicians are very confident in sort of putting in one embryo and still waiting for a 60% implantation and pregnancy rate. Having said that, I would now, okay, thank you. So why did this masterclass idea even come to my mind? Last 8 to 10 years, I've been getting repeated requests from fellowship students in reproductive medicine from all across the country that they wanted to join our physical classes which we held in Gangaram twice a week. But somehow that platform we could never provide to these students. So eventually this year I thought, let me do something to provide some type of ethical and very well-read information to these students who are now going to be the future of our country, the clinicians who are going to run the baton of IVF for us. And hence the thought of starting the master classes. And if you read here, it is an immersive online experience, and it is so much for me that every master class, you all think I teach, but I take home one message and I apply it pragmatically in my practice, and I find great results. And I could name those tips which I got from these master classes. We've done 20 so far. This is the 21st. So every month, starting from February, we've done about 3 master classes. We just leave out one Thursday, and that's it. The moderators for this class very graciously, Dr. Tejashri and Dr. Bhavani, they motivated me, कि ma'am, we will be moderators, we will also help you choose the topic. They ask all the attendees, we've got more than 500 clinicians in this group, and they are such well-read girls that sometimes I don't have answers to all questions. I roll the question back to them only into the online class. That's one of you will answer it, or you put it on the forum, and we will all learn from your answer. Having this, we also have the digital two-way platform has been created by Intas, and I'm very, very thankful to Intas for this, because I had just put up this idea and they agreed, and a two-way online class is very good because even the audience can speak and I can speak. So it is not just a lecture, but it is an interactive class. And those who want to access all the lectures which I have done till now are available on my website, and these are the topics of the lectures. So you can just pick up the topic and see what you want. I've just put a few which could fit this slide. So this is how we go about it. And as Dr. Bhavani said, that it is very important to know that what we must know about embryology. Similarly, we all as clinicians must know how to stimulate our patients, because that is the first step in IVF. If your stimulation goes wrong, everything goes wrong. So the first step has to be right, and we all know that the first step in IVF, which revolutionized the world of reproductive medicine, was the birth of Louis Brown in 1978. And how was Louis Brown created? One egg, one embryo, and a single live birth. IVF started to develop fast with the aim of maximizing pregnancy rates. At that time, clomiphene, gonadotropins, everything was being discovered in 1970s. And high number of oocytes, thus more embryos, was our aim, because our laboratories were very primitive. So we started using unphysiological high doses of gonadotropins, time-consuming protocols, higher cost, patient discomfort because of the injections, because of the large ovaries, patient walking around with heavy ovaries with a lot of pelvic pressure, pain. and higher risk of OHSs, which is completely iatrogenic. It only came up after ovarian stimulation, after IVF, and very high risk of multiple gestation, like you just heard. Rapid progression of protocols and technology started in the 1970s after the birth of Louis Brown. This magic wheel had to slow down. There was no way that we could have continued that type of complication for our patients, and we had to throw it away from our armamentarium. And the definition of IVF started shifting from pregnancy rate per cycle towards achieving a healthy singleton baby per started course of treatments. All we wanted is, we may make eggs, we may make embryos, but we want just one live birth per transfer. So progression of technology started in the 1970s. First, it was controlled ovarian stimulation protocols. Then came in the milder stimulation protocols. But then we saw how many cycles we had to take up to achieve a single pregnancy. It was almost 4 times higher than the stimulated cycle. So this did not stay with us long. And now we have individualized controlled stimulation protocols. So Louis Brown, I already told you, in 1978, single egg, single embryo and a live birth. Start of IVF was with gonadotropin after the birth of Louis Brown. Then we had agonist controlled ovarian stimulation. I'm sure all of you must have used long agonist protocol. Have everyone used agonist long protocol? So we use it, but very sparingly now, because then we got a better protocol, which was the antagonist protocol, which you all see today, all of us are using. Why? Because it reduced complications. And which complications we dread the most? OHSs. So then came in the mild stimulation protocols, but very soon we found that, we need extraordinary good laboratories for this. We cannot give results to patients. Cycle after cycle, we would collect an egg, make an embryo, and make nothing. So then came in, we wanted to make the antagonist protocol even safer. So Paul Deveroy was the person in the 2010-11, he brought in the agonist trigger and segmentation of cycles. So how safe did our IVF cycles become? All those complications flew out of the window, the multiple pregnancy, the OHSs, by just segmenting the cycle and giving an agonist trigger. And last of all, now we have the individualized ovarian stimulation protocols, which we have to fit into every patient according to her underlying diagnosis, pathology, ovarian reserve, and everything. So I could make a few categories of individualization of controlled ovarian stimulation protocols. One is, we need to see type of response, which I'm sure all of you must be doing, right? Everyone sees the type of response. What are the parameters? You look at the age of the patient. The moment she's over 37, there's a bell which rings here. Same is weight, ovarian reserve, and previous response to stimulation. Then you also see what is the underlying pathology for IVF. Does she have endometriosis? And we have antennas growing up that, yes, we will have to do something different here. Male factor, oocyte donors. Donors are the biggest responsibility we have. We cannot jeopardize their health, because they are giving something to our patients which help them, realize their dream of parenthood. We cannot put their health to risk. Then there could be underlying hormonal balance. Please recognize it, whether it is PCOS with LH hypersecretion or hypogonadotropic hypogonadism. Both need to be dealt differently. And then we have a miscellaneous category where estrogen sensitive tumor patients come. I had a breast cancer which is estrogen sensitive, but I want to undergo IVF. You must know what to do. You cannot increase the risk of her breast cancer with your medicines which you use for IVF stimulation. Similarly, prothrombotic conditions. She's had DVT, she's had a filter put into her IVC, but she wants IVF, and you cannot refuse. What do you do? Same is fertility preservation before cancer therapy. Today, I think every month we have 4 to 5 girls who come in for fertility preservation before the cancer therapy and advanced maternal age. I won't bore you a lot. I'll go zip through all the presentations, because you must know just the salient points, what you need to use for every category. So identifying response, you see whether it is a hyper responder, whether it is normal responder, or it is a poor responder. These are only 3 categories of responders we have. identify by underlying PCOS, their build, their weight, the age, FSH, AMH, AFC, and previous hyperresponse. Once you've identified, then let us see how you would treat all these three categories. For normal responder, first I take you the majority of patients. I wouldn't say majority now, because now I think the poor responders are becoming majority in all our practice. Okay. I have this bar which has come in. How can I close this? Okay. All right, but you can see everything very clearly. So please understand, do not go for so many combinations, permutations which you see on the horizon today. Everyone is giving every drug for a normal responder. There's either a long protocol or a short and tag protocol. Please limit yourself to these two and you'll find it so convenient for your patients, for yourself, for your students, for your younger colleagues who are working with you to learn. And, okay, right, thank you. So it is long protocol antagonist or even a short agonist protocol, which I haven't practiced in the last 20 years. But it still comes up in books, so it's best to know that you do use a GnRH agonist from day 2 also. And there are algorithms which use age, AMH, and basal FSH, and you can see wherever the dose gram is, you look at age, you look at AMH, and you know that this is the dose of FSH which you must use. And I'll tell you, the ART law was written by seeing this for donors, that their aim was 7, which is truly illogical, but yes, what they wanted was that not more than 10 oocytes should be recovered for donors and we should not stimulate. Similarly, you can use AFC. So those who are great lovers of AFC can use AFC, those who are great lovers of AMH will use AMH. And so now we come for high responder. This is our responsibility. We cannot let them have ovarian hyperstimulation syndrome. Girls have died, they've lost their arms, they have lost their legs, they've lost their eyesight. So those were the days when we started the GnRH agonist protocol. So here the first choice is antagonist protocol. This is universal for all of us, and all of us should know that antagonist protocol, if it does not work or we have any problems, then we go to the then we can go to the long agonist protocol. Very rarely. I would not take a patient off a high reserve for long agonist protocol. Otherwise, you can go for minimal stimulation protocols where you want to make very few eggs. But then again, I'm not a proponent of minimal stimulation protocols, nor do we use it very rarely at our center. But they can be used for hyper-responders, even to obtain fewer eggs. Prevention of OHS should be our prime importance, and all protocols where the response is high should not be started. 150 should be the highest dose. I think at the most, to give it a very safe bet of not landing into poor egg collection, you can go up to 175, but not more than that. Then comes OHS's free clinic. You all know that antagonist protocol, agonist trigger, and segmentation. So I'm sure all of you know this. There's such well-read audience over here that I'm waiting for questions to come back to me where I would be questioned that this is probably not right. Problems is, so you made a large cohort and you made too many follicles and you've taken out a lot of eggs. What else happens apart from OHS is she would have pain, bleeding. They call you in the middle of the night and say they cannot lie down on the bed because the ovaries are so large that they cannot, adnexal torsion. And I think one of my colleagues has the highest incidence of adnexal torsion where large ovaries are left behind. Rarely thromboembolism. And no fresh transfer. You cannot do a fresh transfer. That opportunity is gone. You have to freeze all. And now with freeze all, so much research is going on, macrosomia, childhood cancers, and the need to freeze all the embryos, and the problem of keeping the frozen embryos, how long and how many. So we need to have oocytes retrieved during IVF. You know, very clear balance. This is a very favorite slide of mine. Normally, in a high responder, I would say you have stimulated the patient very well if you get up to 15 oocytes. The moment you get more than 15 oocytes, please vitrify all the embryos, whatever the case may be. Do not attempt a transfer, because if she gets pregnant, she's had it, that girl. She would end up with a OHSS. Now, poor responder are our biggest problem, and the Poseidon group categorization has shown that almost 40% of the patients coming in for IVF are poor responders. Protocols, again, antagonist protocol, because we don't want to suppress the gonadotropin. Adjuvants, now the latest adjuvant permissible for less than 35 is growth hormone, androgen, and CoQ. Nothing else. No other adjuvants. So please do not go on adding medicines, because she will forget to take the most important medicine and will go on to all these adjuvants which have nothing to do in her cycle. And pre-treatment for cohort formation, this becomes very important for poor responders, that we need to have a good cohort, and you give a pre-treatment. You all know, antagonist, estrogen, whatever you want to use. So this is the review which was published in September 2019, where you see best practice in Poseidon group 3 and 4. Whatever the age may be, the reserve is low. Less than 35, more than 35. And if you see, it is, you may give adjuvants, you may not give, but the protocol which is suggested is now long protocol. Why did the long protocol start getting more favor in this? Because the cohort formation is best in long protocol. Whatever you do with giving priming with estrogens, antagonists, the cohort is never as good as the long protocol. So otherwise you do antagonist protocol with priming, or you do duostim, which we were the first ones to publish a paper from India. Hard work from 2018 till now, and last year, or this year, February, we published this paper on duostim. Now we are doing another paper on bistim. So the idea is collect more embryos, collect more oocytes, because you need to give a baby to the patient. So don't just try to do one embryo transfer, make more good embryos, so that at the end, you stop stimulation and she can have her family completed. But the summary is, we are still researching on poor responders. We don't have a final answer. We are trying to generate more eggs so that we make more embryos. But the final point is that one day when we will be able to enrich the cytoplasm of these women, mitochondrial transfer, then maybe we will be able to do away with so many cycles of stimulation. Hormonal imbalance. Now, all of you have a question, and I know even my colleagues of my age and caliber say LH levels are high, I don't want to start stimulation now. So what do you need to worry about it or no? Well, there are so many papers to support that you may need to suppress, but then there are so many papers which say you don't need to worry about LH levels. If you see, the varying levels of LH did not affect the cycle outcome, and similarly, LH estimation is not mandatory also in a PCOS woman. However, we always do it. So that can go out of the screen. You can ignore basal high LH levels and start with antagonist protocol. My FNB student is not here who did a paper on this. And after that, I have been convinced that we don't need to suppress this LH level. However, if you are of that group who feels that you need to suppress, then either you revert to long agonist protocol, or you go to pre-treatment with oral contraceptives for 2 or 3 cycles so that the LH levels come down by negative feedback. Having said that, hypo is the best group to treat. No agonist, no antagonist. Just give them gonadotropins. Whenever you want, give them a trigger and take them up for IVF. So this is the easiest group to treat and gives us the highest chance of pregnancy. Don't forget to give pre-treatment to these with estrogen and progesterone so that we can sensitize the uterus with these two. And underlying diagnosis, severe endometriosis is the pain for all of us. Why? Because low ovarian reserve, because of ovarian disease or surgeries, poor oocyte embryo quality, impaired endometrial receptivity because of HOXA10 and alpha-5 beta-3 integrins going low in these patients. So in all patients, we look at ovarian reserve and age of the woman. Here we also have to look at the stage of endometriosis. And surgical pre-treatment may be required. I'm just charting out that if the endometrioma is large or there is severe pain and the patient cannot live her life because of the pain, you have to do surgery before IVF. Diagnosis in doubt, you're not sure whether it is a malignancy or it is just a simple endometrioma. Then And if you find that you started an IVF cycle, you could not reach any follicle, they were all distant to the vagina. So your needle did not reach them. You will have to operate on her. And these are the cases where you may do nothing or you may give medical treatment. Like small endometrioma, previous surgeries done for this, low reserve, advanced stage. Aim of ideal protocol is good number of high quality oocytes. Where do we get this good number now from? How do we get it? And we also need the best endometrium for implantation. So the two protocols again come to our rescue. The long GnRH agonist protocol and antagonist protocol. Both are equally effective, so do not give more weightage to the first one. Our old papers in 2007, the Cochrane review said, oh, very long down regulation is very good and the live birth goes up. All that has been refuted now in the most recent Cochrane library, which says that nothing happens if you give prolonged down regulation, and you just need to. Male factor, you have to do nothing. Just treat the woman on her parameters. Oocyte donors. This is one very important category which I want all of us to understand. As clinicians, you're all got off in the arena of clinical practice, and it is important that no oocyte donor goes home with any complication. So what is the requirement of oocyte donor? Minimizing trips to the clinic, protocol which limits the number of injections, reduced risk of ovarian hyperstimulation, pain and other complications, and they want other things like reimbursement of their expenses, want to be treated with respect, and a lot of them want to know the outcome also. We cannot treat them as a piece of vegetable because they are in need of money. We have to give them their due respect. So first thing is, whether we give antagonist protocol or agonist, the donors will have good number of similar quality oocytes. Agonist trigger best option as risk of OHSS is further minimized. We don't have to do embryo transfer, so where is the problem? And then is PPOS protocol is so good. We've been using it in our IVF center almost always, off and on, doing studies on this. PPOS protocol, I'm sure you all understand the progesterone primed ovarian stimulation, where the second injection is gone. So you've minimized her injections, you've minimized her monitoring, you've minimized her trips to the hospital also. And last of all, monitoring E2 levels, nothing is important with PPOS protocol. So sometimes suppression may be excessive, but you have to identify, like Gaurav said, that we would have fertilization failure in 3 to 4% patients. But then you have to balance the risk of all the things and the excessive suppression of LH where the trigger may not work, the agonist trigger may not work. Last of all, prothrombotic. I'm sure all of you get these patients. I don't know whether you refer them or you treat them. Stop referring them. If you're doing IVF, treat them yourself. Prothrombotic or oncologic issues requiring low estrogen levels. Low estrogen can only be met by one thing, that is adding letrozole right from day one of stimulation to your gonadotropin, and you can go on increasing the dose of letrozole to 10 milligrams. We like to keep the E2 levels to just 300, maybe at the most 400. These are books which say up to 500, but I don't think our patients have more than that, and you still get 10, 15 eggs, very good quality, and they make perfect embryos. So these are patients who have estrogen sensitive malignancies like breast malignancy, endometrial malignancy. Number 2 is addition of low molecular weight heparin in patients who have prothrombotic conditions, like anyone who comes that have had an attack of DVT. Always add low molecular weight heparin to her stimulation. You will save her from another attack. She will not point her finger at you that you've led her to another one. Last of all is fertility preservation, which has started coming to us a lot. Girls who are going to go through cancer therapy, they just come and say, I have 15 days, can you preserve my eggs? That is when you have to learn random start. Random start means just start the day the patient comes. Just do a baseline ultrasound, a baseline profile hormone, and start her injections then. Don't worry whether it is the 7th day of a cycle, or 2nd day of a cycle, or even 10th day of a cycle. A scan and LH progesterone levels will tell you whether she's nearing ovulation, she has already ovulated, or she's going to ovulate in the next 3 days. And we've done it with excellent results. If the follicle is less than 12, on the day your first scan is done, you can add an antagonist. If it is more, just give her gonadotropins, let her ovulate, and go on stimulating her in the luteal phase. You will be rewarded with very good eggs, which culminate into very good embryos also. Last is luteal phase COS. This we're doing in duostimulation already. And any woman who walks in on the 14th, 15th, 16th day of her period saying, my cancer treatment is going to start in 15 days, start her stimulation right away. You don't have to wait at all and tell her that, no, you have to come on day 2 like we do for all other patients. Having said that, advanced maternal age, if you see over here, this chart shows that you need so many more eggs. At 44 years, the pregnancy rates are 2%. Please realize this fact, tell it to your patients that if you want to use your eggs, your reserve may be very low. We may have to stimulate you multiple times to get 12, 13, 14 eggs, and still we will give you a pregnancy of 2%. Please make them understand it, put it into their heads. Because when you get eggs and you make embryos and they don't get pregnant, they forget all that. So it's very good to give them a written information also that so low are the pregnancy rates with self eggs. And besides, if you see one euploid embryo, then the number of cumulus ovorous complexes which you get are much more when the woman is more than 43. Same as androgen levels reduce with age. And quality of oocyte also goes down due to mitochondria being depleted from cytoplasm. So one answer for all. Possible reasons and ICOS treatment. Individualized controlled ovarian stimulation, long GnRH agonist protocol or antagonist protocol with pre-treatment. Starting dose has to be recombinant FSH 300 units. Now again, I want you all to remember, please don't increase the starting dose to 400, 375, 450 or 600. I've seen a starting dose of 1200 also. Please do not resort to those practices. These women have limited number of eggs and you can only stimulate that much. And 300 is a good dose to stimulate whatever the woman has. More than that you cannot make because she does not have. And you can add LH, which is a very good thing. You can add androgens. You can do duostim, you can do bistim, you can do luteal duostim also. These are all methods of oocyte collection and embryo formation. Having said that, I take you to the summary of prerequisites for ICOS. You have to, first thing is identify the ovarian response. And I think all of you have this, that you will see the age and you will look at her ovarian reserve, whether it's AMH, AFC, FSH, E2, whatever you see. Then identify coexisting hormonal imbalances which could affect controlled ovarian stimulation. Determine underlying pathology requiring need for change to alternative protocol for optimal ICOS. So underlying pathology could be endometriosis or it could be hypo-hypo. Complete safety for oocyte donors. This is my foremost, I should have put it as the first point. Prothrombotic conditions require additional attention, lower the E2 levels and give her something which will stop coagulation in her body temporarily, like low molecular weight heparin, and it has to be a daily injection. And oncologic issues, you have to remember you cannot let them wait even one day. So the day they come, you start it the same day so that they can go for their chemo and you don't delay or you don't let the cancer progress for them. Liberal use of vitrification to optimize results, and as you've seen that vitrification gives us more than 95% recovery of embryos. Vitrification of embryos is very good, even vitrification of oocyte is very good. And in advanced maternal age, it has to be duostim, bistim, luteal stim, anything. So what would ICOS and ERT for maximizing success eventually mean? A cycle with ovarian stimulation which gives the couple best chance of singleton pregnancy with lowest or no risk of OHSS. You don't put the patient, these young 20, 30, 40-year-old girls who want to start a family, you cannot make them morbidly ill. I have had patients with kidney failures, with so many problems in the earlier days when we did not have these protocols. And minimize the chance of cycle cancellation. So remember, ovulation induction is not only science but an art, and I will bring my last slide, which I always give a life lesson after all my master classes, which is what is learning and teaching? What we are doing here is learning and teaching. When I teach you, I first have to read myself. I have to learn. Once we learn, we watch our colleagues or seniors do something, then we think, is this logical or is it not? Don't follow anyone blindly. Always think, and then you do. So this is the life lesson I would want to give all clinicians and our young budding, I don't have embryologists here, but all our clinicians, that this is important. Thank you. So this is the 21st masterclass which Tejashri and Bhavani have been moderating for me. I mean, they have been so generous that whether they are in the clinic or anywhere, they sit in the class, they listen, they put up questions, and we always have about 100 to 200 people who join us for these online classes from South India, from Maharashtra, Mumbai, Pune, and Bengal. Do we have girls from Bengal? Yeah, okay. Thank you very much.
Thank you so much, and I'm sure you're all mesmerized and more educated today evening. Would we have questions from the audience? We would like to have few questions if somebody wants to ask.
For your mesmerizing talk as always. So like you said that we gave oral contraceptive pills to reduce the LH levels, maybe 2 or 3 cycles. So while giving oral contraceptive pills, there's a lot of literature which says that it decreases the quality, you should not use that. So what's your experience? Because I have not found such bad quality of embryos when I'm using it, maybe for one cycle, either for synchronous growth or maybe to plan the cycle for someone.
I just told you that I would not reduce the LH.
Yeah.
But if you've got this in mind, there are a few clinicians who've got this in mind that, oh, LH is high, I need to reduce. Then you can do whatever you want, whether you use agonist, but agonist is very dangerous in PCOS,
Yes.
you understand. Then OC pills become the choice. And whether you compromise on quality or quantity doesn't matter to people who have their own thinking, and do not read literature to know what works.
Yes, ma'am. Thanks.
Any other questions? Everything was understandable.
So I have one question to Gaurav. So Gaurav, you mentioned that you would suggest IVF in ICSI failures. So for the benefit of audience, I just wanted to know who are these patients who will benefit after ICSI failures with IVF?
Yeah, so these are these are patients who've had ICSI in non-indicated cases with normozoospermia and basically no indication for doing ICSI, and they've been having multiple failures after failures.
So they have embryos but they're not getting pregnant, right?
Yeah. So possibly then one should risk trying natural insemination and natural fertilization, which will increase your likelihood of making more embryos, better embryos, and might prove to be very productive for those patients who are unnecessarily going through cycle after cycle, getting subjected to a procedure which is not indicated, and while maybe all this time all they needed was just
Natural selection
natural selection to work.
So we had a few odd patients where we have done
yes,
that, yeah.
Many.
That when you do IVF instead of ICSI, does it mean that the eggs have time to mature which were not mature when you denuded them for ICSI? Yes. They have time to mature in the next few hours.
Right. That happens, and that's what makes the whole difference. Where once the eggs have been inseminated, then assuming that we'll have the same proportion of immature eggs even with eggs where IVF is being done, but they spontaneously mature in culture, and when they do so, they become available for fertilization, but which cannot happen with ICSI, where we physically denude the eggs and then we discard the ones which are immature, because immature eggs don't fertilize. So there we've seen there's almost a 25% reduction in oocyte utilization, which is the game changer.
No other questions? Then we can proceed with the rest of the thing. Tejas. Question in EI Cosmic?
Your master classes have been very effective.
Shalini is the one who also puts up a question in all the online classes. She never goes without a question. From your comments, I learn.
Ma'am. We all learn from you, ma'am.
I would just request Dr. Neeti Tiwari ma'am to come forward and felicitate our speakers for today. Abha ma'am, please come. Dr. Gaurav sir. Thank you so much. Now moving on, the most awaited part after ma'am's lecture and sir's lecture is now going to be the coffee table book unveiling program. So I would say that this book was a brainchild of Mr. Satpathy from INTAS and was orchestrated and created by Mr. Bobby and edited by Miss Elsa. It is a tribute to Dr. Abha's unwavering dedication and passion, and we would know more about ma'am, the facets which were unknown to most of us. Her story serves as a reminder that we all have this power to make a difference and we should draw inspiration from her life. For this program, I would like to invite on stage Dr. K.D. Nayyar sir, Director, Akanksha IVF, and one of the most senior IVF practitioners of Delhi. Welcome, sir. Dr. Shweta Mittal, ma'am. The famous, well-known and most loved Secretary, Indian Fertility Society. Mr. Satpathy, Executive Vice President, INTAS. Welcome, sir. We would also like to have upon stage Dr. Gaurav Majumdar, sir. Senior pediatrician, and most importantly, all the energy behind ma'am's, all the work that she does. Thank you so much, everyone. I would now request Dr. Sakshi to come upon stage, Dr. Neeti ma'am to felicitate today's guests. And now the chief guest of this program, Dr. Abha Majumdar, ma'am. Ma'am, please come on the stage.
Thank you so much. I'm so indebted to Mr. Satpathy for even having originated this idea, which was couple of years ago when he said, I want a coffee table book made on you. And how much effort he's put into it. Mr. Bobby would come to my house every weekend, write scripts, we would edit, we would re-edit, take pictures. I would sort of scramble all my albums, all my media to find some pictures of my past when cameras were not so common. And that is how the creation of this book took place. It was printed about a little before, but it is being sort of unveiled today only, all by the efforts of INTAS and all my colleagues who are here. Thank you so much.
Thank you so much, ma'am. Dr. K.D. Nair, sir, I would just request you to say a few words.
I think
Please be seated.
I must to congratulate Dr. Abha Majumdar for achieving this landmark, and we are all looking forward to see this coffee table book, what is being written there, and how has been her journey. I must congratulate her all the efforts. Thank you.
I would now call upon stage, dais, Mr. Satpathy, to say a few words.
In fact, I have written few words for ma'am. I think I'll read out. Hope you all would like it. We honor of a healer, wise and kind. We gather here with hearts entwined to launch a tome that shall unfold the life and work of Dr. Abha Majumdar Bold. Her story whispered in every page, a narrative of empathy, skill and sage. A journey each with care and grace. In this book, her spirit finds a place. From days of learning, humble and bright, to guiding hands through darkest night. Her tender touch and wisdom sought. In this coffee table book, her legacy is caught. A healer's life, a canvas of love, resonates beyond and high above. The impact felt, the life she has saved, in these poetic pages, her essence draped. Through trials faced and victories won, Dr. Abha's tale shines like the sun. A beacon of hope, a guiding star. In this book, her billions travels far. So let's rise a cheer, a toast to thee, Dr. Abha Majumdar, are honored and worthy. May this coffee table book forever stand, a tribute to healer, compassionate and grand. Thank you, ma'am.
I request Dr. Shweta ma'am to say a few words.
So, hi everyone. I think if I have to really speak from the heart, it will take a very, very long time to speak about ma'am, but I can really tell you that 20 years back, when I came to Delhi, then I was very new. Even in my interview, other than ma'am, I knew no one. So the first home I found for myself was ma'am's. So this is really a fact. In my happy days or in my distressed days, I knew that I had one home where I could go, and that was ma'am's. So if I have to really summarize her 5 very important characteristics. In fact, my sister came yesterday and she wished her happy birthday on 12th. And the first thing she said, that she sounds so young. So I think that energy, that enthusiasm, that Botox, which keeps coming out of her all the time from her personality. And the second thing, what she told me while we were just coming, she said, you know, you have to become a very warm person the way she is. Every time she meets anyone, the person feels very warm. So these were the 2 things what Nupur told me in the car today. But 5 very important characteristics which I think that ma'am really possesses. One is integrity. So when it comes to her work, it is ethics and it is transparency. So I think that has been, been practiced by her, taught to the juniors, and then it goes on, I think, generations after generations. The second I always see is a creativity. So very recently, I can say, we're talking, she's thinking, and the research department says that, oh, let's do something on microbiome. And then, the whole research on microbiome will start. So this is how it happens. So I think very creative, very adaptable in very difficult situations. So this is her 1/3 very strong characteristic. She has a lot of empathy, a lot of, I think, It is called Abilities Beyond the Sky Limit, and that is what she does, supporting some age-old homes. I don't think I'm still at that level, but someday maybe I will reach, and most important is very humble. So even as a junior, like my journey, I think what I loved was the independence what was given, which is difficult, you know, when you are under a very big umbrella. So giving that independence of work and expanding your wings. So I think, ma'am, that's you, and we always look up to you.
Dr. Shweta, it was really emotional to listen to you. But we also have Dr. Neeti to say something. And I'm sure all ma'ams, juniors, and everybody wants to speak. Let me know if somebody wants to speak for 2 minutes. Dr. Neeti.
Good evening, everyone. So I find myself very fortunate to be chosen by her 17 years back, to be mentored by her after that, and to be working with her even today. And I agree with whatever Dr. Shweta said, her qualities. And 3 things which I have learned from her all these years. First of all, that keep learning always. She has always been a learner, and we all know her as a teacher of teachers, but you people don't know that she has this never, say know-it-all attitude. She's ready to learn from her juniors, she's ready to learn from her fellows, and that is why she is what she is. And still so passionate about making her slides. I don't know how many people of her age do that. So well versed with the technology we learn from her while we are making our PowerPoint slides. So always ready to learn in every aspect. Second thing which I learned from her is her philanthropic work which she does to give back to the society. The common teacher we share, Sister Shivani, who's from Brahma Kumaris, who says that always be a giver. So she is the epitome of that. Always be a giver. And she has been, connected with Earth Savior Foundations for years now. I'm sure before that also she was doing a lot of, and she spent her entire birthday, in the Earth Savior Foundation. This thing, she just cut the cake with us, and then she went there and she celebrated her birthday with the destitutes and orphans in the Earth Savior. So that is one thing which I really want to incorporate, because that comes back to you later in life, and I really look forward to that. And a third thing is the way she has balanced her life. She has never compromised her personal life besides being in such a heavy practice, and I'm sure her family sitting here relates to that. Never ever, she was there for every functions. She takes times off when her daughter comes, and all the vacations, and we work as a family, we have a group practice, and she has helped us to develop that. And now when we also go on a vacation, we know that we have a team which is looking after our patients, So she has developed that kind of practice, that kind of confidence in all of us, and that is really something which I have learned to balance everything, and a multitasker she is. Thank you so much. Thank you, ma'am.
I know we can go endlessly and keep speaking, endlessly about Dr. Abha. Dr. Shalini Chawla wants to speak for a minute, and then we'll move ahead.
I feel Dr. Shweta and Dr. Neeti has reverberated my thoughts also for ma'am. And it's been 20 years that I'm associated with ma'am. And one day ma'am told me that you are just like the umbilical cord, which can never be separated from me. So all the qualities, ma'am, the best quality is like, of course, she is a role model, I guess, for many of us. And she'll never hesitate before any presentation. She would make the presentation maybe like 15 or 20 days back, which I think, unlike all of us, we would make it last 2 or 3 days. She's so well planned. She would read it and she would discuss it with all of us as juniors, take our inputs, and not only, I know better than you and all, never, never, never. And I think it's been like any doubt, you're a troubleshooter, first call goes to ma'am, what should we do? And she would very, very, very well explain ki, okay, this is the solution. And so many times I would call her back, ma'am, you suggested this and this patient has become pregnant, you know. So I think the more I say, the less it would be. It's just, ma'am is like, ma'am, God bless you. We are really willing to read your book and we want to know you more and more. And good wishes for your health.
Last but most important, we have Dr. Gaurav Majumdar. We certainly have to listen to sir about what he has to say about ma'am.
I just took 1 minute from Tejashree. I just wanted to say one thing. Dr. Abha Majumdar is a person who is well known, a very hard worker, balanced her life very well. But the best part was, today I was feeling very proud when I saw the mother and son sharing the same platform. That was wonderful. And I feel that when you're the youngsters, when your children grow up and you stand with your kids, with your son or daughter in the same platform and deliver lectures, teach people, it becomes an immense happiness, satisfaction to the rest of the family members. I won't take much of my time, but it's wonderful, Tejashree and Bhavani. They did a wonderful job, and every time I see these girls, they have arranged this at a very short notice, and my gratitude to Mr. Satpathy, my dear friend. He had been always with us, and Abhaji, keep up the good work. Keep on teaching. There are so many students. You have to carry on your job, and also look after me. I am also growing old. As she said, Niti said, balancing between the hospital and the house. Yeah, that is very, very important. Otherwise, I don't know what I am going to do. Thank you very much. Thank you for coming.
Thank you so much. It was really nice to listen from everyone about ma'am. I also had to say something, and that is coming through a video. This opportunity I received to make a little video about ma'am, which is going to run for another 3 to 4 minutes, and it's interesting.
A doctor with Midas touch, a clinician par excellence, an inspiring teacher, a diligent administrator, a loving wife and a caring mother, a perfectionist to the core, one woman in innumerable roles played to perfection. Ladies and gentlemen, Dr. Abha Majumdar. The story of her life will inspire many to pursue their dreams and continue to persevere in their chosen field of work. Dr. Abha Majumdar was born on 12th of November 1952 in the city of Jalandhar. Life was tough for young Abha and her siblings after her father's death, but she emerged victorious from every challenge that life threw at her. A brilliant student in school, her teachers encouraged her to appear for the pre-medical test. In 1970, Dr. Abha started pursuing medicine in SN Medical College, Agra. Graduated as a topper in 1974. She won the Chancellor's Medal for the Best Student of the University and President's Silver Medal for the Best Girl in Medical Graduate in 1974. Her pursuit of knowledge and excellence led her to pursue master's degree in obstetrics and gynecology in SN Medical College, Agra, where she met the love of her life, young and handsome Dr. Gaurav Majumdar. Dr. Abha and Gautam got married on 1st of February 1979 and till today he stands tall and firm as her pillar of strength. The couple went to Libya in pursuit of achievements, modern hospitals and with European doctors and lots of exposure for 5 years. And Dr. Abha wanted to come back. They came back to Delhi and she joined Sir Gangaram Hospital, settled there and started enjoying her job. When medical community in India was only waking up to the wonder of IVF, Dr. Bhandari, the then HOD of Obstetrics and Gynecology, entrusted her with the task of starting the IVF unit at Sir Gangaram Hospital. Along with Dr. Mohinder Kochar and Dr. Raj Gaur, Dr. Abha started IVF unit and their first success came soon after in February 1991. The team delivered the first IVF baby, Garv, on 21st September 1991. Soon under the guidance of Dr. Abha, the team expanded and the unit became known as the Center of IVF and Human Reproduction and is now a huge team with a comprehensive state-of-the-art facility for reproductive health care in a professional and friendly environment. Apart from all the professional roles that Dr. Abha plays, family for her comes first. Whenever in need, she puts her family first. With her 3 children, Dr. Gaurav Majumdar, Astha and Pooja, the twins, are doing very good in their life and are now parents to children. Dr. Abha loves to spend time with her grandchildren. When asked about how she balances work and personal life, she says she believes in multitasking, makes a to-do list and continues to work without wasting a single moment. What an inspiration! She is also a philanthropist at heart. 2012, she founded Daya Agrawal Education Trust for financial support to meritorious students. She is also closely associated with an NGO, Earth Saviors Foundation, founded and run by Mr. Ravi Kalra. Dr. Abha lives a holistic life. She starts her day with a physical trainer, walks, aerobics, badminton and table tennis, swimming are her regular interests, likes to watch Bollywood movies and loves to travel. A godmother giving priceless miracles to couples who have otherwise given up hope believes that we need a good and strong legislation to safeguard mothers as well as the unborn child. The ethical, transparent, and honest medical professional, she is not only known for IVF but is still known for her mettle in managing high risk obstetrics, and patients from all over the country are referred to her.
We take immense pride of our center at Sir Gangaram Hospital, and over the years I've seen it go from strength to strength. However, when I look back, I think it is not just this which gives me happiness, but it is to gain our patients' faith in us. And more than that, it is that little feeling that we are responsible somewhat for their moment of joy. And it is this reward which makes each one of us strive for excellence.
When discipline, patience, hard work, perseverance, and ethics is bundled into one human being, it makes someone like our beloved Dr. Abha Majumdar.
Nupur is here. Who else? Dr. Manchanda is here. So I'm very thankful for all of you. And there is an army officer also here who has come with his wife. And I told him he'll get bored during all these lectures. I can't see him, but okay.
Please come forward for the cake cutting.
Everyone's side. It's very nice, very nice. Sanjeev, Bhavani, all of you come here, anything, picture now, yeah, Dr. Manchanda, please. Nupur, आप मैडम आ जाइए यहाँ किसी और को फोटो लेनी है प्लीज।
अरे तो ये निकालना पड़ेगा ना सब कुछ।